So this is the January 2021 MEC Minute, and topic for this month is going to be the 2021 protocol review. So the protocol for 2021 has been approved. It was approved by the chiefs earlier this month. Really, we were about 3 months behind our usual process. Typically, we have the protocol done in September, and then we use the last 3 months of the year to socialize and train to the new protocol. But COVID has affected a lot of what we do, and that's included our development and revision of the protocol. So we're a little bit behind, but we are going to issue a new protocol. So this is a review of that protocol. The protocol is effective March 1st. So we're abbreviating the training time we have, but the protocol will become effective March 1st. It will be posted in ResponseSoft on March 1st. So on March 1st or after, as soon as you can, please update your version of the app on your device, whether it's a phone or a tablet or a PC. So please remember to upgrade or revise and download the new application, the new protocol. I suspect you'll get a reminder after the 1st of March when you open the app for the first time. We also have developed, as we have in the past couple of years, a written 2021 protocol assessment. We have a video that accompanies it. It's Dr. Stoner and Battalion Chief Weber and myself. We've added Chief Weber this year as kind of our color commentator. Our expectation is that all providers complete the assessment by March 1st. We want to use the assessment as part of our learning tool for the protocol. We encourage group participation. So really, I think you learn better, we all learn better if we participate in a learning activity as a group. So this could be done as some process you arrange within your station. The assessment is pass-fail. There is no passing grade. We're not expecting 70% or better on the scoring, but we really expect you to take it. So in order to pass this assessment, you have to take the assessment either again alone or as a group learning experience, and then view the video that we issue. Typically it's around 90 minutes. Review the video, which kind of goes through our answers to the questions and explains our thought process for picking the answers that we do. As part of the protocol revision, there is always a list of changes. The list of changes will be distributed to your EMS coordinators as a separate 4-page document, but it really is extracted directly out of the protocol. And if you go to the protocol when it comes out, it'll be on pages 328 to 331, and it essentially lists all the changes to the protocol. If you look at what we've done for protocol changes this year, most of the changes are little changes in terms of formatting or punctuation, corrections that we've identified over the past year. So there are really this year, in terms of changes to the protocol, there are only several that are major, and I will discuss them later in this talk. But all of the protocol changes, even the little ones, are listed on the list of protocol changes that are identified in the back of the protocol. So please take a look at the change list and make sure you're aware of the changes. Again, most of them are small. So if you talk about the changes that we've made, I've come up with a quick list of those changes that are relatively small or don't require a lot of discussion as part of this presentation. I've got a list for children as for adults, and here's my quick list for adults. The first is that transcutaneous pacing is now part of the protocol for bradycardia if IV access is not readily available. So if you have a patient who is symptomatic, secondary to bradycardia, typically third-degree heart block, but they're symptomatic. Could be lightheadedness, they could be passing out, they could be hypotensive. If you can't get ready and quick IV access, then just apply the pads and start transcutaneous pacing while you're working on IV access and medication therapy. So we have added transcutaneous pacing. It's always been there, but we've revised it and added it as an option that you can take from the onset of first contact rather than having to go through a series of other interventions such as IV access and intravenous medications. So if the patient needs it, but you don't have ready access, go ahead and start the pacing and then use medications as you obtain IV access. Based upon the recommendations from the American Heart Association this fall, we've added rapid transport of pregnant female patients in cardiac arrest, particularly patients who are in the second half of their pregnancy. Typically, if we're talking about asystolic or PEA arrests, we tend to work them at the scene. But if you have a pregnant female in cardiac arrest, our focus is on rapid identification of arrest and immediate institution of CPR, defibrillation if necessary, and then rapid transport of the patient to the receiving hospital. I would take the patient to a facility that has obstetrical services available, which is pretty much readily available for all of our service areas. Notify the receiving facility that you've got a pregnant female in cardiac arrest so they can mobilize their obstetrical service, and then displace the uterus to the left. If you have a large pregnant uterus and the patient's flat on their back, you may have that uterus sitting on the vena cava, which impedes venous return to the heart, which means you have less blood to circulate with compressions. So if you displace the uterus to the left, you'll get that uterus off of the vena cava, you'll have improved venous return to the heart, and your compressions will be more effective. The other thing we have done upon request of many providers is we have added the midazolam intranasal dosing chart to the adult and pediatric seizure pages. So this chart, this table, remains in the procedure section under MAD, but we've also duplicated it on the individual protocols for adult and pediatric seizures, so you don't have to go flipping through the protocol in order to find the dosing schedule. For adults, it's pretty straightforward. It's 10 milligrams IN or IM. For children, though, you'll have to weight dose them. So we put this where it's readily available for your review. So you should see that. And again, it was done at the request of several of our providers in the field. Moving on to peds, here's kind of our pediatric quick list. Dr. Stoner has gone through almost all the pediatric protocol. We've made some revisions. We added some listing of possible causes of arrest in a child who's post-arrest, so we've added possible causes for PA and asystole. Nothing on that list would surprise you. For hypovolemic shock, we have revised a little bit. We had the wrong number of repeat boluses listed. So currently the revision is going to be for a hypotensive patient, hypotensive pediatric patient who is hypovolemic shock, they would get a 20 milliliters per kilogram bolus, and you can repeat that bolus times 2. If you look at the existing protocol, it's times 3. That was an error. So the total volume that we're going to give a patient in hypovolemic shock is 60 milliliters per kilogram in 3 separate 20 milliliter per kilogram boluses. We've also added, for convenience sake, IV infusion rates to the pediatric IV section. In the past, we have not had that. So I know we've had providers confused over, okay, I've got a 15 kilo child, how much fluids do I give them? So we've added a flow rate for that. We've added a targeted O2 sat for neonates, so from 1 to 5 minutes or 1 to 10 minutes post-birth, where would we expect to see their oxygen concentration, and where would you want to use oxygen therapy? We've added ibuprofen for febrile seizures if the child's over 6 months and able to take oral fluids. We have revised a little bit our dosing schedule for albuterol and Atrovent for children who are suffering from bronchospasm. The previous protocol had an interval in between the first and second dose. The new protocol will basically say you can give albuterol and Atrovent back to back. So when the child's finished 1 dose, they still need more. You don't need to wait 10 minutes. You can give them a second dose immediately. We added CPAP to lower airway protocol. I'll discuss that later in the slide deck. And then for burns, we have eliminated the Parkland formula for children. So we're no longer going to flood children with IV fluids based on the Parkland formula. The new protocol will say IV fluids at a maintenance rate, which is based on the schedule that we've got posted in the IV section, and we will give a 20 milliliters per kilogram fluid bolus as needed for hypotension. So my understanding is through Dr. Stoner that the process for children is no longer to flood them with fluids based on a Parkland burn formula. We give them maintenance fluid plus boluses as needed to maintain an adequate pressure. So I've alluded to 2 different charts. There are tables that we've added, and those are here. The first has to do with the IV infusion rates. I just want to point out that for a child that is between 0 and 10 kilograms, their IV infusion rate is a flat 4 milliliters per kilogram per hour. So if you have a 5 kilogram child, they're going to get 20 milliliters of fluid in that per hour. And then for the higher weight children, it's going to be a flat rate based on where they fall. So we don't want you to have to do fluid calculations to get a bit more complex over 10 kilos. It's basically if a child is in this range, if the child's between 10 and 20 kilograms, they get 60 cc's an hour. If it's 40 to 50, they get 90. If they're over 50, they get 100. You give them a fluid bolus if needed because of hypotension, but this is the maintenance rate that you would use in the field. The other table that I alluded to had to do with our targeted SpO2 in neonates. So at 1 minute, our target SpO2 is 60 to 65, and at 10 minutes, we expect them to be close to normal. So if you have a child, a newborn that's has a SpO2 at birth of 45 to 50, well, we're going to stimulate the child. We're going to give them high flow oxygen to get their O2 sats up. So this gives you an idea of what we would expect to be normal in a child who is, or a newborn who is just delivered. So we've added that as a reference for you. I like to spend a little bit more time talking about some what I would consider to be significant changes, and there are not a lot of them. The first has to do with our infectious airway protocol. We added this in the spring in response to the COVID pandemic. We are transitioning from what we were calling an infectious airway protocol to protocol regarding aerosol generating procedures. So what we've talked about among the EMS coordinators is, do we even need this at all? And it's really my feeling that we set an expectation of how we approach our patients and what amount of PPE we use. So for all patient encounters, we are expected to use surgical masks. We're expected to use gloves. We're expected to do a standoff assessment to determine what is necessary. But we also realize that our COVID patients or our patients with respiratory symptoms may still need airway adjuncts. As part of our response to the COVID pandemic, we minimized use of CPAP, BiPAP, endotracheal tubes, and nebulized medications. Our process from this point forward is if the patient needs an intervention, we provide it. However, if the patient requires these interventions, since they are aerosol generating, or should the patient be in cardiac arrest, we're going to gear up and we're going to at least airborne level precautions. So if you have a patient who requires an airway procedure or airway adjunct, or a patient's in cardiac arrest, the expectation is that we have eye protection on, that we have a N95 or higher mask on, that we have a gown or some type of covering on our clothing if we have it available. And then we use gloves. So essentially, we have removed the restrictions on airway procedures in patients who may have COVID, but there's an expectation that regardless of the type of patient you're dealing with, if they need an airway adjunct such as an endotracheal tube or CPAP or nebulized medications, we are going to have airborne precautions in place before we start the procedure. So I think we need to continue doing this. I think COVID has kind of reminded us that we should have been doing some of this in the past. Now it's clearly stated, and I think we'll keep this in place until we're well out of the pandemic. So we've changed it again. We've basically changed it to the aerosol generating procedures instead of infectious airway. It's still in the same place in the protocol in terms of sequence. And again, there's this emphasis on we will give the patient all the care they need regardless of their illness. But if we have to provide any aerosol generating procedures for the patient, or if the patient's in arrest, we are going to make sure we're wearing airborne precautions. We have airborne precautions in place as we care for the patient. We have made some changes to allergic reaction. I think for those of you who've listened in the past, I've been harping on everybody with allergic reaction gets epinephrine. Well, Dr. Stoner and I have had an ongoing conversation for the past couple months, and he's convinced me that if you have a patient who has itchy skin or has hives, they don't necessarily need epinephrine. So we have adjusted both the adult and the pediatric protocol. So mild reactions get diphenhydramine or Benadryl. Patients with symptoms of anaphylaxis, which could be respiratory distress, angioedema, and so on, get epinephrine first, and then we give them ongoing treatment based on the algorithm. So continues to be an emphasis on early administration of epinephrine for anyone who has symptoms suggesting anaphylaxis, but if it's a mild reaction, mild symptoms of allergy, we're going to go with Benadryl. So the pediatric and the adult protocol look almost identical. The only difference is children have focus on weight-based dosing. So we tried to keep them simple and consistent. And in future efforts on the protocol, you'll see more of an effort to make sure the algorithms between adults and children look similar. So again, we've discriminated between allergic reactions that are mild and those where it's true anaphylaxis, and the treatment plan is based on that. We've also made some changes in behavioral, both children and adults. In the past, for behavioral patients, if we've given them ketamine, we've also co-administered midazolam. Well, there was a recent consensus document released by multiple professional societies, including the American College of Surgeons and the National Association of EMS Physicians. And this document reviewed the use of ketamine by EMS, and it covered issues such as pain as well as need to use ketamine for behavioral emergencies. And the recommendations are now that if you give ketamine for behavioral emergency, you not administer Versed or midazolam. We use midazolam or Versed in these behavioral patients with ketamine to avoid what's called the emergence phenomenon when patients start coming out of the sedation from ketamine. Well, it turns out that only about 5% of the patients who get ketamine will have symptoms of emergence phenomenon, which typically is hallucinations. These hallucinations tend to be short, and if they do occur, they can be easily treated with a benzodiazepine. However, if we have a patient who gets ketamine plus midazolam, they're much greater risk for needing airway interventions such as use of a BVM or other ways of maintaining their airway. If we do not use midazolam with ketamine, that risk of need for airway support is much less. So the bottom line is we are going to take away the increased risk of airway issues by not using midazolam, but we will use it in that small percentage of patients, again it's estimated to be 5%, that have emergence phenomena, in which case they will get midazolam, but the other 95% will not. So the big change here is we took out that arrow that goes between ketamine and midazolam. So if you have a patient with behavioral emergency, give them ketamine, either IM or IV. Don't worry about giving midazolam. If you have a patient who is agitated but not violent or combative, then you would continue to use midazolam by itself. So the only change to this graphic for children and adults is that arrow between ketamine and midazolam being removed. We've made a couple revisions to the MAD table under the MAD procedure, and like I mentioned earlier, we moved this table to adults and pediatrics for seizures, but we've revised this table in that we have added ketamine in terms of using it for pain control and as well as for using for pediatric CPAP, and I will talk more about this in the next slides. So for pain control, we've made some changes that I think will be for the better. So one of the first things that I like to talk about is we have changed the maximum dosing for fentanyl for children and adults. So the dosing schedule for IV and IO fentanyl and intranasal fentanyl is unchanged. But in the past, we had a limit on adult dosing at 200 micrograms unless there's a major injury or a major burn, in which case it's 400 micrograms. But we've now changed the maximum dose to weight-based. So the maximum amount of fentanyl a patient can receive is 4 micrograms per kilogram, and the unit or the amount given for each dose is also based on their weight. So if you have a 70 kilogram person and they need fentanyl for pain control, you give to them IV, they're going to get 70 micrograms up to a total of 4 doses, which would be 4 times 70 or 280 micrograms. So the total dose, the maximum amount of fentanyl that we'll give a patient without online medical control authorization to go higher is 4 micrograms per kilogram. And that's total, whether the patient gets it IV, IN, or a combination of the two. The other thing we have done is we have added ketamine as a first-line medication for use to manage pain, and it is first-line medication as an alternate to fentanyl. So now if you have a patient with significant pain that requires medication for pain control, you can opt to give the patient ketamine instead of fentanyl. Who might you give this medication to first rather than fentanyl? Well, think of the patient who is drug addicted, is a history of current use of opioids, or has a history of opioid addiction and is now on Suboxone. These patients will take a large amount of narcotic to get adequate pain control. They may have difficult IV access, so ketamine is a better option for them. So if you have a patient with a tibial fracture and they need medication for pain control, ketamine is probably a better option for that patient if they suffer from addiction or they are in recovery and currently on Suboxone. And the ketamine can be given IV at a dose of 0.3 milligrams per kilogram to a maximum of 30 milligrams, and it's the same dosing schedule for children. If you have no IV access, then we could also use ketamine in adults and children as either an intramuscular injection or an intranasal administration. So for adults, if you have a patient with poor IV access and they need something for pain control, you can give them a single dose of 50 milligrams of ketamine IM, and it's a single dose, and the dose is the same regardless of the patient's size. You can also give them intranasal ketamine, and for children, you give intranasal ketamine as well. So you do have that available as an option. The other thing that we still have is ketamine still remains an option as to augment fentanyl. So if you have a patient with fentanyl failure, they still have excruciating pain, you can give ketamine intravenously at 0.3 milligrams per kilogram, and that is the same in children. So we have much more available to us as options for pain control in the field. Ketamine works very well. It works quickly. I really like it for patients who have poor IV access and who need immediate pain control. I've had several trauma patients where I give them a dose of ketamine IM, and it buys us 10 to 20 minutes to obtain adequate IV access and to get the patient's pain under better control. I would suggest that if you have a patient who's opioid addicted or in recovery, you use ketamine or think of using ketamine as your first-line drug for pain control. Talking about some pediatric issues, pediatric bradycardia, we've basically reworked the algorithm, so we have 3 arms to the algorithm as seen on the right rather than 2, and it's based upon what we do if the patient has no pulse or has a pulse rate but is bradycardic versus they have a heart rate over 60. So this is something to think about. You know, a heart rate for a child is going to run higher, so our definition of normal heart rates is different for children. If the patient has a palpable pulse and their heart rate's over 60, we're going to treat them with fluids. If their pulse rate is less than 60, we'll consider using pacemaker. Whereas if they're totally without pulse, if they're asystolic or have PEA arrest, then we'll treat them as an arrest. So I think it's a similar concept to what you've seen. It's just got 3 arms to the algorithm instead of 2. I'd like to move on to pediatric CPAP. We are going to start using pediatric CPAP with the new protocol. It's been utilized and promoted by West Louisville Fire. Granted, their experience and volume of patients is relatively low, but it works and helps about 50% of the kids. Dr. Stoner has recommended that we add it. Columbus Fire is planning on adding pediatric CPAP in February as part of their protocol update. How is this different from adults? Well, we use the same CPAP circuit. So the circuit that you use now to administer CPAP to adults can be used in children. We just use smaller masks. We also use ketamine to sedate the children because, younger children, particularly those under 10, will have a hard time with a mask on their face. They'll become scared, they'll become more anxious. So we are advocating use of intranasal ketamine to pre-medicate children immediately before applying the mask. The other thing we would like to emphasize is that if a child requires CPAP, chances are they need CPAP because they have bronchospasm and they are failing. We would like them to continue to receive their nebulized medications via the CPAP circuit. It's also something good to do for adults, but we really like to emphasize it for children. There's a burden on us to also update our receiving institutions. So, for Franklin County agencies, we tend to go all to Nationwide Children's, where pediatric CPAP is well known and well utilized, whereas Genesis and Fairfield Medical Center, Licking Memorial Hospital, we'll have to update them, let them know what we're up to. I also hope that we'll have a YouTube video available soon that you can view to see how to set a child up and put them on CPAP, how to size them for the appropriate mask, and so on. So looking at some of what's in the protocol, on the left is the lower airway lower airway respiratory distress protocol. I've taken out a portion of it. And if you look at, you see that red box at the bottom corner on the right, it says consider CPAP. The child has to be over a year of age. We'll start them at 5 centimeters of water. You can bump it up to 7.5. And then we also have the appropriate size mask, and we also reiterate that we want you to continue to use nebulized medicines through the device. If you look at this graphic, it suggests that ketamine is an option for tolerance. Actually, if you look at the checklist that we have as part of our CPAP protocol, ketamine is down as an expectation. I think you should use ketamine in the children, particularly those under 10, because they will become scared with the mask, particularly if they're already having airway issues and they're struggling to breathe. On the right, I've got extracted from the protocol indications and contraindications. So, patients that are candidates are children with acute respiratory distress. Do not want to use CPAP if they have pneumothorax, because it can cause a simple pneumothorax to become a tension pneumothorax. We want the child to be reasonably awake and alert. They have to be over a year of age, because otherwise the mask may not seal well. We want them to have a GCS of over 10. We all want them to have evidence of respiratory distress with increased work of breathing and tachypnea and tachycardia. We want their blood pressure to be acceptable. It's nice to see other indication of respiratory distress with accessory muscle use and maybe some retractions. We do not want to use the device in the patients who's in respiratory arrest. If they're in arrest, they need to be bagged, intubated, or have a supraglottic device. If you suspect pneumothorax after listening to their chest, we do not want to use the CPAP device with pneumothorax. If the patient's got distended stomach or they have a history of low cardiac output, it's not a great device to use. If the patient's hypovolemic, they may need fluids before we put them on CPAP. If there's any evidence of penetrating chest trauma, we should not be using the device. Nausea and vomiting is an indication or a reason for us not to use the device, because they can vomit and then aspirate if the mask is in place. Patients with trachs or have any mid-face deformities or previous or recent surgeries may not be able to use the device, and tracheostomy CPAP is useless. Patients who are impaired mentally, who have active GI bleed, who've got vomiting, who really are not breathing well, they're not a good candidate for the device, and you should use them with caution. You have to discriminate maybe between simple nausea versus active vomiting. If a child's not adequately breathing, then the device isn't going to work well. They're going to need a BVM or other airway support. Excessive secretions may be an issue if they require a lot of suctioning, particularly if it's lower airway. And again, facial deformities can be a problem and make CPAP an issue. I pulled out a couple pages specific from the protocol. This is the checklist, the protocol to use pediatric CPAP. Again, we're going to use the proper indications and contraindications. We're going to start them at 5 centimeters of water, and we can bump it up to 7.5 if we have to. For now, we're going to keep that as the upper limit for pressures. I'd like to call out fitting of the mask. There will be a template that you can use to fit the mask so it fits the child correctly. Again, hopefully we can review that in a video. Also, on the second page, we emphasize the use of ketamine to pre-medicate the patient. Ketamine will make the child more calm. Ketamine also helps as a bronchodilator. It does cause the airways to dilate, so it does have a positive effect in terms of treating the asthma itself. Yes, it may cause some increased secretions, but my experience is that the increased secretions are less of an impediment than the improvement we see in the patient's respiratory status by using ketamine. The other thing I like to call out is just reemphasize that if the patient has received or should receive bronchodilators, we continue to give them via the CPAP device. You can do that with a separate line, second oxygen source, and you can feed the acorn right into the airway or the circuit of the CPAP device and continue bronchodilators for these patients. So that's what I have for the update for this year and for the MEC Minute. Please review the protocol changes before March 1st. Please complete the protocol assessment and view the video that's going to come out. We should have that done the first week of February. If you have any questions about the protocol, please reach out to your EMS coordinator, who can then either answer your questions or reach out to Dr. Stoner or myself to get you the answer you're looking for. So thank you for your time. Be safe. Please study the protocol.